Hi, everyone, and welcome to a live chat with Nurse Linda. Today's topic is healthcare tips. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Now I'm going to turn it over to Linda. Hi, Linda.
Hi, thank you, Julia, and welcome everyone. It's nice to be with you today. Today is a very special day in my life personally because it is my brother's birthday. So I want to wish my brother a very happy birthday. It's a milestone year for him, so good for him. It's always nice to hit one of those big markers in life. Today we get to talk about just some general healthcare tips, and I've just written kind of a potpourri of information this last month of March. It's been a long month. We're kind of coming out of the bad weather. We may be coming out of COVID, maybe not. We don't know. We have to wait and see. So, you know, things are plugging along, though things seem to be improving in that regard. So some of the things I talked about, and one thing I really want to bring up and highlight is some myths about spinal cord injury. And I get a lot of questions, and people will say, well, my spinal cord's completely severed, and I had a spinal cord injury and my spinal cord's completely cut in half. And I just wanted to bust that myth because that's usually not the case. The number of people who actually have severed spinal cords is like so minuscule that it's unbelievable. Where the confusion comes is when they do that ASIA scale assessment, you know, where they measure all the movements in your joints and they measure each dermatome of sensation as they go down the body. So if you have a spinal cord injury, you've had one of these tests. And what that says for level A type of injury is that there is no communication at the very last segments of the spinal cord S4 and 5. So they do the rectal exam. They find there's no communication, that the message isn't getting through to the tail of the spinal cord. So they call that a complete injury. Now that terminology, and in medicine, there's a lot of terminology that gets muddled. But in that terminology, many patients and a lot of healthcare providers too will say, oh, you have a complete injury. That means your spinal cord is completely centered. No, it does not. It does not mean that at all. So sometimes people will write and they'll say, well, there's really not much hope for me because I have a completely severed spinal cord injury. And I always say, you know, probably not. And it's not being snide or anything, but probably not. It's very difficult to have a completely severed spinal cord, even if you have an injury from a knife going through it. There's still some fibers left that are connected. If a bullet goes through it, I mean, you'd have to go in and really, you know, cut that spinal cord in half. And that just, you know, the odds of that happening are so minuscule. Now, there are a few people that have had that, but that it is just really a small number of people, like, you know, not even 100 of all the 250,000 of people in spinal cord injury. I don't know that that's a fact, but it's, you know, it's such a small number of people. So if you're thinking your spinal cord is completely severed, you have no chance, you have no opportunity, forget that. You probably, more than likely, your spinal cord has some threads that are going through. So that's just an important thing to remember. Another important thing to remember is that some people say, well, the nervous system doesn't regenerate. So when I was in college, probably when you were in college, and people would go out for beer on the weekend or two or more, and they'd say, well, I'm going to drink this and I'm going to kill those cells in my brain, and they're never going to come back because the brain doesn't regenerate. The spinal cord doesn't regenerate. Well, yes, it does. Yes, it does. The nervous system regenerates just like the rest of your body. Now, we all know that the skin regenerates because we can see that if we get a cut on our finger, we could almost watch it in a couple of days, that cut will be healed up because that's the skin cells regenerating. The skin regenerates very, very quickly because it's the barrier of defense for the whole outside world. So it keeps all the bad things out, and it helps hold all the organs inside of us. It's kind of like the frosting on the cake, if you will. Skin is a lovely organ of the body. So it regenerates very quickly, but those body parts inside the body, they're well protected, so they don't really regenerate as quickly. Bone turns over, blood turns over, all these things regenerate. Living cells die off, they get replaced with new cells. The nervous system is very interested in not only does it develop new nervous system cells, but on the nerve, the axon, that real long piece on a nerve cell, that one really long arm, if it's not connecting to a place that's there to receive its message, it will start looking for someplace else to connect. So your nerves will, if there's a damage in one of those axons, it will start looking for someplace else to connect to. So things sometimes get twisted because of that. Messages get sent the wrong way because of that. So just know that that happens. And then another thing that I really wanted to highlight also as a reminder, and I try to do it every February, but I was late this year. So, and that is sepsis, because that is an infection that goes wild through the body. It's extremely dangerous. So it's very important, if you're noticing any symptoms of sepsis, if you're feeling lethargic, or if you're not thinking very well, you just kind of have the blahs, maybe you have a fever, maybe you're having episodes of autonomic dysreflexia, maybe you're having increased spasms. It comes with, if you have an infection, like say a UTI or a lung infection or something, it will follow, maybe you got an infection on your skin, maybe that cut got infected. It's anywhere in your body you can have an infection. And sepsis comes after you have an infection. Now, it can creep in because sometimes you might have an infection and you might not know it. So especially if you have problems with sensation, you might not feel that you had an infection, so you didn't get it treated. And then the infection runs through your bloodstream. And so your organs start shutting down, your organs get affected. It's really a dangerous thing. It is a 911 scenario. So you want to be sure and deal with that right away, because it's just critically important. Now, they don't really talk about this much anymore, but back in the day, we used to have a thing called the golden hour. And if somebody got sepsis, they would say, you have 1 hour to get it under control, or there's going to be serious consequences. So like I say, this is a 911 emergency. Now, if you are an individual and you've had a brain injury or you've had a stroke and you knew you had an infection, you got it treated, it still went into sepsis, whatever. If you think that you have sepsis, be sure and read all those symptoms. And, it's not something you have to think about, well, do I have sepsis today? Let me see. No, it's not that kind of thing, but just kind of know in the back of your mind, because one of the tips from the Sepsis Alliance is that if you have to go to the healthcare professional, you will want to say to them, could it be sepsis? Because the way people start the way healthcare professionals start identifying what's wrong, they do what they call differential. So they start ruling out. They start with the simplest thing. If it's not that, well, let's go up the hierarchy of problems. And so sepsis is kind of a rare thing. And so it doesn't happen so often, so people don't think about it so often. So if you think you might have that, that would be a time to start talking about that. So we'll just break now and go right into some of the questions, because we have some great questions in the queue today. So let's go ahead and talk about some of those. And the first one is a person who has T6 incomplete injury of 27 years. And during COVID, it's been hard. Yes. I'm going to divert for just 1 second. I also am immunocompromised. And so I went out of the house like for lunch. And I have to say, oh my gosh, being cooped up in the house during COVID, I'm a people person, so I want to get out. So that was very hard. The neighbors brought my food to me and, took care of me. So that was great. And it was a long time to be that dedicated. So I really owe them a debt of gratitude. The other thing is COVID was hard for some people who are hearing impaired. My mother is extremely hearing impaired, but she reads lips. Well, in COVID, everybody had a mask on. So it was just impossible for her. She really became even more isolated because she can't talk on the phone. She talks on the computer. And so that's helpful because, she can see our lips while we're talking. So as long as she has the visual, she does well, but that was really hard. So when COVID's starting to let up and the spread in my community is very low. So I thought, okay, I'm going to lunch with a friend. Oh my gosh, such a big day. I planned my outfit. I mean, this was such a big day. I'm going out in the world. And I found that was really even harder than staying in because I was so anxious to be outside. So all these things are kind of normal. So I just want to mention that if you're feeling adventurous, maybe you've already been out, still take precautions. People with neurological injuries often are immunocompromised. So you still want to be cautious. So I go out, I see everyone without their mask on. We isolated we chose a particular restaurant where there was a table where we would be separate for everyone. So we felt comfortable with our mask off. But then also, I see people and they're just like out and about, without masks, no mask at all. I'm like the only person I feel in the world still wearing one when I go out. But, we still have to be cautious, some of us. And so don't be ashamed of that. Just do your thing, what you have to do. So this person, T6 incomplete for 27 years, a warrior for 27 years. I like that term. He's going in for his fourth Botox bladder treatment. So he wants to know, is there anything that you can do for those bladder spasms? Well, Botox is really the treatment du jour these days for any kind of spasticity. If it's in your legs or your arms, or if you have spasticity, they give an injection of Botox. And what it does is that it affects some of the cells in the bladder or in the muscles of the leg or in the arm, or women who get it in their face. So they get rid of all those wrinkles up there, here or here. I could use a Botox mask, I think, on my face. But anyway, so what it does is it just affects a few of the cells in there at a time. So very few, and less in the face. Because something like your leg, a bigger amount. They also do Botox injections in the back of the head for migraine headaches, which is kind of an interesting thing because that seems to work well for a lot of people. The reason why people prefer to go to the Botox is because it doesn't go through your whole system. It stays locally where they inject it for the most part. And so you can take medication for spasms of the bladder. You can take medication for spasms. Now we call it tone instead of spasms, but most everybody still calls it spasms. But you can take medication for that by mouth. But when you do that, it affects your whole body. So some people become very tired. They get the really dry mouth. They just feel like they're in a fog. It takes a long time to get used to the medication, maybe even a couple of weeks. Eventually you get a tolerance to the medication. And so you have to take more medication, then you have to go through this adjustment period again. So Botox is really a lot more people pleasing friendly. And so that's why you do that. but Botox wears off as well. Those cells will grow back and the tone spasticity returns. So you have to have it done periodically every so often. So there are some other things that you can do for your bladder for function. For tone right now, it's pretty much the Botox, because that's a bladder spasm. So the bladder is a muscle, and it tightens and it spasms, and that can force urine out of your bladder. So sometimes people think they're urinating when they have a neurogenic bladder, but it's really the spasms. It's not the urinating neurological process. And sometimes what happens is your bladder will spasm, but that sphincter that opens up when you urinate, your bladder contracts, the sphincter opens and the urine comes out. If you have neurogenic bladder, the bladder could spasm and the sphincter can spasm. So it's trying to push that urine out, but it can't come out because of that sphincter. So it backs up into the ureters, up into the kidneys, causing kidney damage because the kidneys don't hold urine. So that's why. So Botox of the bladder right now is a really good thing. There are some things that you can do for your bladder. Some people, if they have a low bladder capacity because of the spasms, sometimes they'll get their bladder augmented. They call it bladder augmentation. So they'll have the bladder enlarged to make it a little bit bigger. If you have an indwelling catheter or suprapubic catheter, the bladder is not filling with urine and then contracting as it does with intermittent catheterization. So if you have a catheter in either through the urethra or a suprapubic catheter, the bladder will shrink down because that muscle's not being exercised. And so sometimes people will get a really small bladder because of that. And so then there are, they'll do some different procedures to kind of help stretch that bladder out. So those are some of the things that they're doing. Some people, especially women, who want to do intermittent catheterization. And by the way, if you've had a suprapubic catheter, or if you have an indwelling catheter, and you want to switch to trying intermittent, if your doctor, your healthcare professional agrees with that process, it is a bit of a process to, re-engage the bladder. So it is a bit of a process, but you can do that. There are some people who can't, and everything depends on what is uniquely you. But if you think you would like to try that, that's an option. For men or women, there is a process that's called the Mitra Fanoff procedure. It's especially used by women because when you're out, it's really hard to catheterize because of positioning. If you can't transfer to the toilet and spread your legs wide enough to get the catheter in, some men have a retracted penis that makes it very difficult to catheterize. So there is this Mitra Fanoff procedure. It started in pediatrics. And what they do is they take usually the appendix, but they might take a piece of tissue from within your own body. So there's no rejection process. And they reroute this. They attach it to the bladder and they reroute this appendix. I'll just use the appendix for an example. They reroute it and they attach it to the inside end of the belly button. So what happens is you can do intermittent catheterization through the belly button, which is a lot more accessible, especially for women. If you're out, you want to go out for more than 4 hours, and then I have to go home and catheterize, and I have to get in bed, and I have to position and all this kind of stuff. Or even if somebody else is catheterizing you and it's just difficult to access, you can go into the bathroom, you can do intermittent catheterization through the belly button. So that's kind of a cool thing. So there's all kinds of medications that can be taken also as well. If you have a bladder that spasms, if you have a urethra that spasms, there's a thing called detrusor sphincter dyssynergia, DSD, and that is where the detrusor muscle, that's the bladder, and the sphincter don't work in unison. Sometimes the sphincter's too lax, sometimes it's too tight. Sometimes the bladder's too flaccid, sometimes it's too tight with tone. So there's all kinds of things. You always want to have, no matter what, you always want to have urodynamic testing done one time a year. Now, sometimes people will say, oh, I kind of stopped doing that because I've been going for 5 years. I've been doing it for 10 years. Nothing's ever wrong. And I'm just not gonna bother with that anymore. Well, if nothing's wrong, great. Just consider it a win and move on, because you can be operating in your bladder system, whatever your bladder program is, it can be going on fine for 5 years, 10 years, 20 years, 30 years, 40 years, no problem whatsoever, until one day there is. And because of that link of the ureters up to the kidneys, if you have a problem, you need to get on top of it right away. First of all, it's easier to treat if it's caught earlier, whatever the problem might be in that urinary system. And second of all, you don't want to be waiting for like 5 years and find out, oh, this problem probably developed 5 years ago. I didn't have urodynamic testing, and now I have kidney failure. So you see, the risks are high. You go and you have the procedure. I'm sure most of you have had one. It's not a glamorous procedure. You're sitting there, male, female, you're spread eagle, and people are putting fluids into your bladder and taking all kinds of measurements. But once it's over, it's over. So it's just an important procedure to have done. So those are my recommendations for bladders. The next question, this is a beautiful question. How can we better inform doctors and nurses about spinal cord injury, or really any paralysis? If you have a head injury, if you have a stroke, if you have multiple sclerosis, any kind of paralysis, this person feels like they should know more than they do, or at least they need to research things to see what's going on. Yes, true to all of that. Everyone, doctors and nurses, get educated about spinal cord injury in their academic years. It's part of the curriculum. However, when you're out in the world, most people, and honestly, there are many people in the healthcare profession that have never even seen a person with paralysis. I'm not kidding. So, you might, if you don't have a spinal cord injury specialist, physician, or nurse to see, that's kind of the gold standard, but they're not in all parts of the country, and they're not in all parts of the world. So that makes it a little more difficult. Neurologists will be more up on it. General practitioners, usually if they have someone in their practice that has a spinal cord injury, they will take the time and they will take the effort to do that. Not all of them do. So if you feel like you're not getting the treatment that you need, you might want to ask around in the spinal cord injury community. Who do you go see? Are you satisfied with your doctor? Just as anybody is looking for a general practitioner or somebody to take care of, pediatrician for their child, we ask around. Everybody asks around. What about this? What about that? You can also contact the Christopher and Dana Reeve Paralysis Foundation. They have a mentorship, a group of people, and there might be somebody in your community that you can connect with to see who do they see for their doctor. Where can you go? What can you do? Now, if there's a doctor in your community, but they're not covered on your healthcare plan, call the number on the back of your insurance card and say, I have this issue and I need a doctor who can treat it. And they will have the list of people in the plan who specialize in that particular area. So maybe there's somebody out there in your town, or maybe even the next town over, that does have this specialty, but you're not quite sure about it, or you've never even heard of that person, because there's a lot of people in the world. We all don't know everybody. So those are different things. But I do think that one of the best things that you can do is to know about your spinal cord injury yourself. So much like the sepsis people say, if you think you have sepsis and you go to the emergency room, say, do you think it could be sepsis? Because it gets them thinking about it. So I think if you educate yourself, now you don't have to know all the medical ins and outs, but if you really know bowel, bladder, skin care, those kinds of things, that's a start. Know what your medications are and why you're taking them. You can also get from the Reeve Foundation, there is a book, and they can send it to you over the internet or on a memory stick, or you can request a paper copy. It's a great big spiral bound book. Well, it's a book about that size, but it's thick. It's a good inch thick, and it has just like everything you need to know about spinal cord injury. Now, you don't want to sit down and maybe read that from cover to cover. Some people will, but at least if you have that kind of information, or if you go on the Reeve Foundation and you want to know more about different particular topics, there's all kinds of information there that you can find out about. So if you have a spinal cord injury, or if you've had a stroke and you need to know how to do bladder care, or you need to know how to care for your bowel after paralysis, it's all there. So you can print that off, take it to your doctor and say, you know, I've been wondering about this. There are some emergency cards also on the foundation. They call them wallet cards. They're trifolds. They fit in your wallet, and they're for really important things like autonomic dysreflexia, deep vein thrombosis, a blood clot, sepsis. They're for things that are really dangerous situations. You can keep those in your wallet. And if you have to go to the healthcare professional, you can pull this out and say, I got this card. There's a special place on each card, instructions for the healthcare professional. So you can hand that to them in a gentle way. Don't here, use this card, but you can say, I have this card, I have a spinal cord injury. I think, I've been diagnosed with autonomic dysreflexia, or I think I might have a blood clot. And this is the standard of treatment for these particular ailments. So they're very good because those are emergency situations. But the more you know, the more you're going to be able to correctly relay your symptoms to your healthcare professional. So that's important. You don't have to be the healthcare professional. You won't be diagnosing yourself, but at least if you have some inkling of, these are the questions that I need to ask when I go there, or this is what I need to tell them about. Because I know in my own practice as a nurse, people will come in and they tell me what they think I need to know, but they've forgotten this really key piece to the puzzle, or they just didn't think that was important to the whole picture of what's going on. And so it's not anybody's fault. It's not anything that's wrong. It's just that, you need to get all this information. So if you can help direct that conversation, then that's a good start on how to get going with that. There's a person who wrote in here about how to get started when somebody is newly paralyzed. Well, getting that introductory book is really good. Get started by knowing how to do bowel care, bladder care, how to do skin care. Those are the big three. Now, there are many other important things, but those are the big things. And it's like anything else. It's like going out for the first time in a post-COVID world, or whatever world we're in now. If you think about the first time you drove a car, it was kind of a little intimidating. That's a big piece of machinery, and you're like in traffic, and that can be, it's overwhelming at first, but it gets easier a little bit every single day. And I think the other thing to think about, and it's really hard to think about in the beginning, because in the beginning, your schedule for the day is so overwhelming. Well, I have to get up at this time. I have to catheterize. I have to turn. Oh, I have to do my push-ups. Oh, I have to check my blood pressure. Well, wait a minute, it's a bowel program. Oh, wait, I get to eat now. Oh, finally, there's a meal. Okay. So there's all these different things to do, but it becomes routine after a while. So I think one of the most important things to think about, and this is not something that just, like, okay, I'm going to think about this makes it okay, but it's something to work towards. But one of the most important things to think about is what do I want to do with my life? How do I want to proceed in my life? There are many different junctures in life where we kind of have this conversation with ourselves. We may not sit down and, be talking back and forth to ourselves. We might talk to somebody else, a parent or a spouse, or if you're going to make a life change, but you've had a significant life change. If you've had a stroke, a spinal cord injury, if you have a neurological disease, a brain injury, it's quite a significant change in life. So you have to think about, what do I want to do? How do I want to accomplish this? And then, start setting goals for yourself. Maybe the first thing is, I want to talk more to my friends. So maybe you call them on the phone, maybe you talk to them on the computer, maybe you make that lunch date and you go out together and do something together. Maybe it's just for a short period of time. I know some people on the community website were discussing about going out, and this one gentleman wanted to go out with his friends, and so he did, but he had a lot of healthcare needs, and so he was just kind of nervous about being out in the world on his own. So he went out with his friends in a public area, and his wife stayed someplace else so that somebody could come get her if it was needed. But she was not involved with the group. He was just there with his friends. And it was such a good transition. She did that a time or two, and it quickly became known to them that she didn't need to be there. And so it kind of moved through a progression on how to do that. Some people think, well, I don't have my job that I had before. Maybe it was doing some kind of physical activity that they no longer can do. So, they think about, well, how else could I still do that kind of work that I enjoy? So I'm thinking of one gentleman who was a trucker and became injured in an accident. And so he still wanted to work. He loved driving, he loved trucking. And so he became the dispatcher of the trucking crew. So I get to learn a lot about different jobs and what people do and all the different aspects of it. So, there's that old thing, oh, well, you have a spinal cord injury. Well, you should go into computers. Well, you don't have to go into computers. You can pretty much do, you can do what you used to do. It just might look a little different. And so sometimes people get depressed by that because it's not really what they used to do, and they like doing it. But this happens in life. Sometimes we get older. Sometimes people get laid off. Sometimes whole businesses close up and that job is suddenly no longer available. And then what do you do? So you have to adapt through life. So it's just, another adaptation. And is it easy? And, should you not think about it? Well, no, of course. It's difficult when you get something taken away from you. If it's your job or your livelihood or, whatever, it's, you think, oh, there's a period of time you go through that you think, well, I really don't want this new life, or some people will just charge on through it. So it's a process. So be sure you have somebody to talk to about the process. But to get started, just give yourself a month, 2 months, 3 months, just to figure out all the things. Where do I keep my supplies in the bathroom? If I'm going to go out for a ride in the car, how's that going to happen? How am I going to get in and out of my house if I don't have a ramp? Just think about the immediate, but keep an eye open to the long-term goal of regaining your life, because you can do that and you need to do that. And people do that. So that's an important aspect. So and you might want to have somebody on hand to talk about these things, somebody non-judgmental, somebody who's not your spouse or not your family member, but somebody who's can see things from a different point of view than your immediate world that you're living in. So that can be very helpful if you have a therapist or counselor to talk to. There's a person here who wrote in about they have very low blood pressure, which happens after spinal cord injury because of the autonomic nervous system is not really making those blood vessels contract, and that's what gives you your blood vessels dilate and contract, and that's what affects your blood pressure, how fast your heart pumps. And after spinal cord injury, things kind of slow down. So everybody's blood pressure gets really low. So you need to know what your normal blood pressure is, because I know a lot of people whose blood pressure is normally 80/50, and that's just as high as it's going to be. So when their blood pressure gets, say, like 100/75, they have hypertension. And you think, well, how could that be? Because that's still low blood pressure. But for them, it's hypertension. So these are kinds of things that you need to know. They have an elevated blood pressure. So you need to know what your blood pressure is. And so years ago, we didn't give people blood pressure cuffs, but now we tell everybody, have your blood pressure taken. You can get one of those little cuffs things that go on the wrist here. And you take it always with the same blood pressure cuff, take it different times a day. Know what your blood pressure is so that if it goes up or if it sinks down much lower than your normal, so you have your own normal. It won't be exactly the same every single time. There'll be some fluctuation in it, but you'll get an idea of it's about this. So you'll know if your blood pressure's up. You'll know if there's a problem with your blood pressure, and then you'd be able to discuss that with it. Now, they're having a difficult time controlling it, and they are taking some medication. The other things that you can do to help your blood pressure is to move your body. So moving your body is very important. It's probably, we talk about the big three. Well, there really should be a big four, because moving your body is really critical if you have paralysis from any source. Now, I'm not talking about doing your exercises, okay, I got to do my exercises. I'm going to do my range of motion or stretching. Okay, I've done 10 of those. If you have tone or spasticity, the more quickly or aggressive you move that joint, the more you're going to trigger your spasticity. So always be kind. If you have more of a flaccid body and you don't have any tone, you have a lower level injury, or maybe from another cause you have more plasticity in your body, you still want to be very kind to your body. You want to do your stretching, but do it very slowly, and do it, as much as you can, moving the joint. You don't just want to move it a little bit. Your joint, you want to move the joint completely. And that will help your blood pressure as well. Another thing that helps blood pressure is to wear those elastic stockings that everyone loves so well. They're so easy to get on and off. But be sure and wear your elastic stockings, because that helps return the blood to the heart. You might need to wear an abdominal binder. I want to put a shout out to those who are listening because they have a pediatric individual. So maybe they've outgrown their elastic hose. Everything's going just fine. They don't wear their abdominal binder anymore. That's cool. They're doing well. And then they have growth spurt, especially those boys that shoot like 4 inches up overnight, or the little kids, it's like, wait a minute, these pants fit yesterday and now they're like way too short. So sometimes with those growth spurts, sometimes you might have to revert back to that. But even as adults, you might need to wear it longer than, you thought maybe you would have to wear it. So, these are all things to take into consideration, but those are helpful things that you can do. If you can move your body, that's good. If you use supportive equipment, that's also fine, just to keep that blood pressure up so that you're not faint or feeling dizzy all the time and those kinds of things. Also, raise your head slowly as you try to get up out of bed, instead of, somebody lifting your back and putting your legs over real fast. Raise your head more slowly, get used to that. Sit up at the side of the bed for a while. All those things are helpful, but it sounds like you're working with your healthcare professional. So those are some other things. If you're not on a bladder program that makes you restrict your fluid, increase your fluids. That's another thing. Now, don't start drinking like 8 glasses of water tomorrow or this afternoon, but increase, if you can. If some people are in bladder programs and they have to monitor their fluid intake, but if you have a bladder system like an indwelling catheter or something, slowly increase your fluids over time, like 1/4 of a cup a day. You don't want to overwhelm your heart, which is already working hard to keep that blood pressure up. So it's a slow progression to increase those fluids. Okay, here's a question. Now, those of you who know me know that I'm a vaxxer. I'm very much for the vaccine. So it says, should people with a spinal cord injury get a 4th dose or booster? Well, now I believe that initially they said it was going to be for the boosters, the 4th booster would be for people over 65. But now they say it's people 50 and above can get this 4th booster. So 50 years old, and or people who are immunocompromised. So if you have neurological injury, you are immunocompromised. Now you may say, well, nobody's ever told me that before. No, it's not something that really people really widely discuss in healthcare when they go to the doctor. There are usually many other things, and we're not usually in a pandemic, so it doesn't really come up that much. But the autonomic nervous system is affected in nervous system injury, which qualifies you as being immunocompromised. Now, in reality, you may not be. Your immune system might be working just fine. Somebody else might have an immune system that's really just not working well at all. We don't know whose is and whose isn't. So you can qualify because you have a spinal cord injury as immunocompromised. So I'm all for it. I'm going to get mine as soon as they become available in my area. I'll be there at the door knocking and say, I'm here for my booster. Some people have effects from it. Some people don't. If you're getting the fourth booster, you'll know what your effects are going to be. You can pretty much assume that you're not going to have any horrible consequences. Now, some people say it hasn't been well tested on the population with spinal cord injury or people with nervous system injury. But we do know it's been tested in the general population, and they're studying those specific populations retroactively to see how the vaccines and the boosters affected some people. There are some people whose doctor will recommend that they not have the COVID vaccine. And in particular, those are people who've had Guillain-Barré or who might be allergic to some substance within the vaccine, the makeup of the vaccine itself. And so if you're ready to get your fourth booster, you know that you can take it. Because if you've had three, well, and you've done fine. Now, you might have had a sore arm or you might have been achy for a day, but those are really minor. They go away. That's really kind of minor things. So you can pretty freely take that without too much worry. It is coming out more and more about people with nervous system injury and the COVID vaccine. Now, what you also have to think about is there are like 30 million people in the United States, and I want to say like 300 million people around the world who've had this. And so we kind of know the pockets of people who have had different problems with the vaccine, and spinal cord injury is not in the headlights. Some people with some nervous system injuries, but all that's being sorted out. So if you're ready to have dose number 4 and you've had 3 already, then you should probably, but don't go by what I say, because I only talk in generalities. You are a unique individual. Maybe your healthcare professional would say, no, I don't want you to have dose number 4 because of whatever reason. I think your immune system is fine. You don't have many respiratory infections. You don't have many urinary tract infections, So talk to your own private healthcare, because everybody is so unique. There could be something that's so unique to you that I don't know about. So just be sure and ask about that. The next one is a person who is at T10 para and they have a pressure sore on both their left and right hip. They develop from sleeping on the sides without changing positions during the night. Any advice on speeding up healing? Well, there are some things, and again, I speak in generalities. First of all, you cannot lay on either one of those sides now because they have pressure injury. So every time you lay on those sides, even with your pressure dispersing equipment, you're still putting pressure on that area. So if you stay off that, it will heal up faster. Now, if it's open, there are some medications that you can use to help clean that out. If they're really deep, you might want to get what they call a wound vac, which is a little suction device that goes on the pressure area that withdraws all the secretions that come from that, so it kind of keeps the wound clean and healthy. You'll need to talk to a wound care specialist to find out what specifically you need done for your pressure injuries. You don't want to apply, like if you have a red spot, you don't want to rub anything on that. Some people have these weird notions of putting different substances on there and rubbing it because that stimulates the circulation. When you rub a red area, or if you have darker pigmented skin, it might be a purplish area. Sometimes it looks like what they call an ashy area. Whenever you have a pigment change on your skin in a pressure area, you do not want to rub it, because what are you doing when you're rubbing? You're putting pressure on it. So those who rub pressure injuries are giving you a pressure injury. They're making it worse. So don't rub it. Be sure it's not rubbed. and then do whatever. Sometimes people do wet to dry dressings if it's open, where they take a 4x4 or different size pieces of gauze, put some sterile normal saline on there, and they pack that wound. Then when the gauze dries, they rip that out, and then that makes a little bit of bleeding, and that gets rid of some of that toxic material and helps revive some of this circulation in that area. If there's any infection in there, you'll need to have treatment for that. And then there's all different kinds of things. Now, there's what comes and goes is applying honey-based wound treatments to the area. And so I had to laugh because I have a friend who's diabetic and they got a wound on their foot. And so she was telling me that she wanted to try some of this, one of these honey treatments. So she had a friend who had a beehive, and she got the honey and she was going to start eating that. Well, that's just putting honey into your body. That's not what it is. There's medicinal honey that's sterilized and everything. That's the kind of honey. It's a medicinal product that you buy. Now, some people think they'll take honey from a hive because the honey is essentially sterile, and they'll put that in there, but that doesn't go in there either, because you're putting this foreign substance in there. And even though the honey that the bees make is sterile, the hive is not. And if you've ever been to a beehive to gather honey, the first thing you have to do is get rid of the mice, because they're there for dinner. And so there's a lot of droppings around hives. So you have to get the medicinal one that's the medicine that you put on there. So I do put that out about the honey, because there's a lot of misunderstanding about the honey. So you have to get the prescription type. Okay. So the next question is, what's the most effective procedure or surgery to control female neurogenic incontinence? Well, the most effective procedure is intermittent catheterization, because, and then you do have some fluid restrictions, but you want to control the amount going in and balance that with the amount coming out, because you don't want to overstretch the bladder. You do have to catheterize on a time schedule, because again, you don't want that bladder to become too full and that urine to back up. But the reason why we all go for the intermittent catheterization is because it has that normal stretch and contraction to the bladder. So it makes the bladder work as it normally would work. So that's one thing. There are some surgeries that can be done for neurogenic bladder, especially for females or men. And that is the suprapubic catheter, the Mitra Fanoff procedure, that again involves catheterization. Suprapubic is a little hole made through the skin right over the bladder and the lower abdomen, and then a catheter is placed there. There's the Mitra Fanoff, where you catheterize through the belly button, and there's bladder augmentation. There is also devices that can be implanted. They're functional electrical devices that attach to the nerves that come out of the end of the spinal cord in the cauda equina. And so those are not central nerves in the nervous system. Those are peripheral nerves. And they can put electrodes on those nerves, and you can control your bladder, your sphincter opening, your bladder contracting from your phone. Just get to the right place, and you can, sometimes there's a device in the abdomen, and you just press a button in your abdomen, and they can gear that up for bowel function. They can also gear it up for male sexual function, but not for female sexual function. So there's a lot of things that are on the drawing table for that is available now. You probably will have to go to a specialty area to get that. Not everybody does it, but there are many companies that are coming out with those now. So, it's like right around the corner that's going to be happening. It's really exciting time in research for treatments. It's exciting for cures as well, but there's a lot of treatments that are coming to help people make their life less complicated, make their function better, kind of improve all those kind of things. What can be done for foot drop? And for foot drop, that's when the ankle does not, I'm trying to make my hand like a foot. I can't make my arm, I can't make it bend. This is a laying down leg and foot. So foot drop, the foot just can't be held up like that. There is a real nifty little thing you can get right off Google. And it's a little soft piece of Velcro that goes around here and attaches to the shoelace of your shoe and it holds your foot up. People also wear an ankle foot orthotic, which is that plastic white piece that goes around the back of the calf of the leg, around the ankle, and then it fits on the bottom of the foot. And it's a white piece of molded plastic that you can buy them prefabbed or you can have it made to you. And people will wear that and it holds the foot up. There are also electrical stimulators that you can wear that will hold your foot up. So there's a lot of things you can do with that. There's some surgeries to help correct foot drop. So there's a lot of things going on with that. But what I have found, most people will get through healthcare the white plastic. It's hot in the summer. There's some people wear it, it's no problem. A lot of people complain about it. So when we found this on Google years ago with just that little Velcro strap, and then it just fit. There's a piece that comes across the front and it fits on the tie of a tennis shoe or a dress shoe, and it just holds your foot up. People love that. It's so easy and it's just really inexpensive. So that's really kind of a nice thing to do. This next one is a real interesting question. When I wake up in the morning, my hands feel like a block of ice, her hands and feet. I don't know if it's a her and him, I'm sorry. And what can I do to eliminate this? Well, you first think of cold hands and feet, you think of cardiac issue with circulation. So, that would be one thing to check out. Now with the nervous system injury, it could be an autonomic thing that's going on could be a form of dysautonomia, autonomic dysreflexia. It could be with individuals with spinal cord injury are more susceptible to diabetes because of the lack of movement, especially in your legs. So cold hands and feet can be a circulation problem from a secondary consequence of spinal cord injury being diabetes type 2. So you want to have that checked out. Another thing to think about, because it's in the hands and feet, something that makes me think about is be sure and check your positioning, that you don't have your hands or feet stressed too far this way or too far this way, because you could end up with carpal tunnel, and that can make your hands, the carpal tunnel is two nerves that run right through a piece of tissue right through your wrist right here. And if your wrist gets extended too much or your hand gets extended too much, your elbow gets bent too tightly. So if you have spasticity, you can have problems with the carpal tunnel in your wrist. You also have it in your foot. You have the same kind of thing. You have these tunnels that run throughout your body. You have some up in the shoulders, some in the elbow. You have them in the hips. You have them in the knees, and you have them in the ankle. There's all these tunnels that run through the body. So for me as a nurse, that would be where my mind would go, especially if it's just in your hands and feet. Now, there's another thing that's neurological, but not necessarily with spinal cord injury, but Raynaud's disease, where people get really cold hands and cold feet. So those are just some things, like I talked in the beginning, where people go through the differential. I'm just kind of going through the differential, and I probably left some causes out, but I'm just trying to, walk through this and think about all the things that it could be, and it could be just about anything. So you would really want to talk to your healthcare professional about that cold hands and feet, because that would be very bothersome. And there could be treatments for that. If it's something with autonomic dysreflexia, you might want to check your blood pressure to see what's going on about that. If it's something with a nerve being entrapped, well, you'd have to have a carpal tunnel release, and that would help that. So, there's a lot of different treatments. There are a lot of options that would be really helpful for that. So that's kind of an interesting kind of thing. I'm glad you brought up that question because that's a little bit different. So here's a person that they have autonomic dysreflexia, and they're no spinal cord injury doctors or specialists where they live. It's not constipation, and not UTI, no skin breakdown. It's not the big three. So pain medication has little effect. No, pain medication won't really affect your autonomic dysreflexia. You have to be sure and check that blood pressure and see what's going on with the blood pressure there to see what's happening as far as, to make sure that that is what's going on. But if you are having autonomic dysreflexia, so your blood pressure is going up, then you will want to talk to a healthcare professional. If you can't find a spinal cord doctor, there should be a neurologist around that should be able to help you with that. Also be sure and get that wallet card from the Reeve Foundation. You can print it right off your computer that explains all about autonomic dysreflexia and information for the healthcare professional. So when you go to the doctor, you can say, I got this card. It's got the Reeve Foundation information on it. So people think, okay, the Christopher and Dana Reeve Paralysis Foundation, they know what they're doing there. And so it's kind of a very non-confrontational way to say, I think this is what the problem is. Now, you'll need to find what the cause of that autonomic dysreflexia is, and it can be almost anything. I had one person who looked at their computer a lot, and they were getting symptoms of autonomic dysreflexia just from the lighting of the computer. The light kind of goes in and out, but we don't perceive it with our eye, but our brain does. And so it was giving this guy symptoms of autonomic dysreflexia, which he had never had before. But the only way he could he knew the AD came when he was using the computer. And he knew that he had the computer next to the refrigerator and on the same power outlet. So that was doing something with it. So he also knew if he wore a baseball cap and sunglasses, he wasn't having the AD. So we had to move the computer into the living room, and guess what? It went away. But there is a group in, I want to say Sweden, but it could be Norway. It's one of the Scandinavian countries that is studying autonomic dysreflexia being stimulated from computer use. So that's kind of interesting because that could be from TV as well. So there's all kinds of things, and there could be something going on in your body that maybe you don't know about, like maybe you're having gallbladder episodes if this is just new. Now, some people do not have autonomic dysreflexia even begin until a couple of years after their injury. It could become with aging. There's also silent AD where we don't know what the trigger is. People get it in their sleep. It was found serendipitously when somebody was doing an experiment on something altogether different, and they had to wake people up and they had to take people's blood pressure in the night every so many hours that were involved in this experiment. And they, had given permission to do all this stuff. They knew that this would happen. And they found that people had elevated blood pressure that didn't have AD in the daytime. So was it something with their heart function at night? Is there something with their dreams at night? Who knows? So they're still working on what the source of that is. So you could be having AD, but it could be silent AD. So you want to get on top of that because it is a complication with the cardiac system, and it does have effect on the cardiac system. So you just don't want to say, well, it's not too bad, I'm just going to let this go. No, you really want to get on top of that and get it controlled. And there are medications to control it, but if you can get to the source, then you can eliminate the source, then you don't need to take the medications to control it. So you always want to get to the source. Now, the cool thing is that there's so many things controlled by the autonomic nervous system. One is the consequence of AD. Spasticity is controlled by autonomic nervous system. That lightheadedness or orthostatic hypotension, we call it, raising your head too fast when you get up, that is all controlled by the autonomic nervous system. Your immune system's controlled by it, your heart beating, your breathing. I mean, there's so many things that are controlled by it. So scientists are looking now into something that will treat the autonomic nervous system instead of treating all these different consequences of autonomic dysfunction. So that's something to look forward to. And if you're an individual who has AD and spasticity and orthostatic hypertension, you know, wow, to be able to correct that would be just fabulous for some people. So I just like to conclude with, there's just a lot of things that are going on. It's a really monumental time for developing treatments. Now, I do want to say that, you know, I just present information. I don't endorse anybody, but it is an exciting time. Now, some people are, I'm not interested in any kind of correction, cure, or whatever, and that is fine. But there's nothing wrong with having information. So if you know something is coming down the pipeline, some people are like, I don't want to hear about it until it's real. I get that, because we've all heard things about this or that. It's been coming for years and there's no progress or not much progress. We never hear the progress. But right now there's a lot going on with helping people function better, which I think is really exciting. So some people who are kind of anti doing anything, sometimes they hear some information about something new. Maybe they just want to file it in the back of their mind and think about it later. But some people are really anxious to have these things as well. So I just present it as information. It's up to you to decide if you want to do something or if you want to get involved or how you can, you know, that is all up to you, because every once in a while, I'm going to hit on something that's going to be just the thing you've been looking for, but you didn't know you were looking for it because who knew it existed. So hopefully we can meet in the middle on that. So I just want you to know that we are available at any time. You can contact me through the foundation at any time. So please feel free in doing that, and I'll see you next month. I do want to make a plug. On August 13th, we're having Dr. David Gator as a guest in one of our interview shows. Did I say August? I meant April. April 13th at 2 p.m. Central, so 1 Eastern, noon at Pacific, and Mountain Time, I guess, would be 11. No, forget that. It's at 2 Central. I'll let you figure out your own time zone. But Dr. David Gator, he's the head of the Miami Project, and he's going to be talking about metabolism after spinal cord injury. So I think a lot of you, by your questions, I think this is going to be an important session to hear how you can just better take care of yourself when you're not using a lot of energy, and what kind of calories and energy expenditure and all that stuff. I'm really looking forward to it. I can hardly wait. So with that, I'll see you either April 13th or I'll see you at the end of next month. Have a great month.